Back in the 1970s, Nobel Prize winner Philip Anderson famously said, "More is different." What he was referring to was the way physics had become preoccupied with describing and classifying individual particles and interactions, up to the scale of atoms. But he argued that if you throw a whole group of different atoms together, things become quite different, and it impacts on all the atoms and the role they play. This is why chemistry is a whole discipline of its own, and not just a branch of physics. I'd like to talk today about how more is different also applies to health promotion and HIV. How when we look at the roles and relationships between all our health promoting efforts in a bigger social and structural system, it can alter the way we understand those efforts and the role the partnerships that support them play. The significant increase in our understanding of treatment as prevention has increased the emphasis on achieving a strategic mix of behavioural, biomedical, social and structural interventions and strategies, generally referred to as combination HIV prevention. As everyone here would recognise, combination prevention is largely consistent and heavily influenced by the tenets of the Health Promotion Charter. HIV health promotion in Australia has, for the most part, taken a social structural approach and tried to resist taking an individualist perspective in its approach with affected communities. An individualist approach tends to see members of the communities as risk takers caused by deficits such as irrationality, youth, low self-esteem, depression or isolation, and the focus is on the individual in the community who needs to be counselled or taught skills. It also tends to see risk factors like a series of on and off switches that we, health promotion, can fully control. I would argue that true health promotion takes a social, cultural, more interactive perspective. The focus is on the cultural and interactive practices and structures that produce contexts where HIV transmission can occur or be minimised. It is the community, context and system as a process that is addressed, not only the individual, and resists a simplistic single cause-effect view. It is in this complexity that programs based within the community and culture, such as peer influence and community empowerment and engagement, and peer-led social marketing, have such strength. Treatment as prevention and combination prevention, more than ever, require us to understand our investments and efforts and the role each of our partners plays within this constantly adapting and evolving system. We need to consider the interrelationships, the dynamics and the consequences if we are to get the mix right and keep it effective. Let me explain this a different way by taking you back to some high school science. There are a range of factors that could could impact on the quality of the water cycle, and this could be represented like this. A range of aspects around, say, ground infiltration, stream flow, evaporation, clouds, precipitation, and so forth, all impacting on a water cycle. However, as we know, these factors are not independent, but highly interrelated. The outcome of one affects the process and impact of another. Here we have a diagram showing the various systems and interrelationships in the water cycle in a very different way. The diagram shows not just the overall system cycle, going from oceans, condensation, around ice melt, groundwater and so forth, but also the interrelationships. The diagram shows the subsystems within the actual overall system. How well this system functions and how well it responds to changes impacts on the health of the overall environment. The ecological sciences would never describe the role of a cloud to impact on the health of an environment with no reference to weather, ocean, rivers and so forth, with no reference to the impact of changes like, say, volcanoes in the short term, as shown up in the top left corner, or climatic change in the much longer term. The parts are interrelated whether we want them to or not, and none of these factors are described as simple on and off switches. They would never do that in the ecological sciences, and yet we tend to sometimes, or some of our programs tend to approach those the same way in very complex health promotion programs, as though they're not interrelated. So this brings us to systems thinking as a tool to help us understand and use complexity much more strategically. One of the challenges I've had in my research with community and peer-based programs has been the tendency for some programs, funders, partner organisations and evaluators, and shall we say some of our political detractors, to reduce the idea of peer or community-based response to a single definition and a linear dose-response concept. It just doesn't fit with the actual experience and reality of practitioners I've been working with, nor does it fit the theories underpinning the programs. It was this sort of frustration the last couple of years that led me to the field of systems thinking and approaches, and has had a large influence on the direction of our What Works and Why project. Systems thinking is a collection of perspectives and analytic approaches that share in common a capacity to examine the bigger picture, that is, a problem and the context in which it's embedded, as well as the individual pieces that make up the larger picture. Systems thinking is concerned with the non-linear relationships, the bidirectional feedback loops, time-delayed effects, basically the structure, dynamics and patterns and sensitivity of an overall social system. How things are connected, with what consequence, and to whom do they matter? Rather than the impact of interventions simply being added up as though they're independent, it points us to consider the multiplication or amplification effects of one factor over another. Systems is concerned with how we understand and act effectively within that. System science has its origins going way back to the 1930s, and I'd argue unashamedly draws on social theories, epidemiology, economics, political science, modelling and so on. But its emerging use in public health is fairly recent. Some have argued that systems thinking is part of an evolution around planning, evaluation and learning in public health and health promotion. As shown here, sort of a progression around kind of experimental designs through to the development of program logic, to development of program theory and so forth. Conventional program logic and its inputs, activities, outputs and outcomes is extremely useful when taking a narrow view of a project. However, it can miss the significance of the interaction and dynamics beyond this, the very factors that can have an overwhelming impact on its role and impact in a health promotion mix. Many see systems as more of a progression of these models rather than something completely new, looking at how all these program logics and program theories perhaps fit together in a larger and less linear system. So how might systems approaches help us in regard to maximising opportunities such as treatment as prevention, and how does this relate to partnerships? Let's look briefly at the aim of increasing HIV testing as part of a broader combination prevention system. We could just list the interventions and services, but we know that listing them is not necessarily the whole picture. So we've got all these, I've listed here a whole range of aspects that impact on, or we believe impact on increasing HIV testing. However, we know there's a whole range of social, cultural and other factors that impact. Access to and convenience of testing, cultural meaning of testing, anti-stigma initiatives, stigmatising events, health system changes, and so on. However, the levers to increase testing are not just a bunch of arrows all pointed at testing. They're part of an interrelated system where the quality, dynamics, or outcome of one impacts another. The arrows may only be effective or sustained if the more distal influences are occurring. The reality is that the social, structural factors, inputs, outputs, strategies and so on, are all interrelated. So I've tried to symbolise that perhaps with concentric circles flowing in different directions. And I've refrained from a full systems diagram, as I don't think that would actually work that well on a slide. We'll be looking at those in more detail later in this conference. Combination prevention is not a series of unconnected parallel interventions. And so here we have, for example, treatment as prevention as part of that. What's key is the relationships, dynamics and influences between all of those factors around treatment as prevention and how they actually influence each other to get to, for example, increasing one aspect of it being increased testing. Let me highlight some examples of how systems approaches may help us emphasise and evaluate the quality of these interrelationships. We know that social marketing can be very effective in achieving increases in testing. but not by itself. To sustain any impact, we need testing to be easily accessible, we need social acceptance of regular testing, we need to reduce and minimise the impact of stigma, and frequent testing, and impact of frequent testing needs to be visible and at a social and a network level. And sure, look, all of those sort of interrelationships, that's Health Promotion 101. But do we actually think through some of those connections in planning and evaluating our programs, or when thinking about partnerships and alliances, or when working out what works, what doesn't work, and why? For example, how well does community development and engagement strategies with, say, sexually adventurous men or with young guys create an environment in which social marketing about testing actually has increased credibility and relevance? How well does the Sexually Adventurous Men project share its insights and challenges about these evolving cultures? How well does social marketing initiative about stigma interrelate and amplify the effectiveness of, say, peer outreach or peer workshops to have a more sustained impact on testing frequency? Another one we might want to look at is peer-led testing. How well does the qualitatively unique knowledge gained through conducting peer-led testing feed into social marketing and community engagement about not only testing, but perhaps about stigma, about sex partying, about gay youth networks? How well do focus groups conducted, say, in the development of a testing campaign feed into the provision of the actual testing services? How is this complemented by and compared to other sorts of targeted social research? Another one I'd like to look at is perhaps around positive programs, or programs with people with HIV, and engaging on a peer level. The advocated move from greater involvement to meaningful involvement of positive people reflects an emphasis on quality participation. But what does that really mean in social and structural system? For example, what is the role of all community participation, engagement and leadership in the system? What does community leadership need to achieve and to enhance and play an effective role? What are the parts of the system that can amplify or reduce the overall influence? What does each program here need to do to make all these other levers more effective? Health promotion, in the end, is about enhancing and reducing factors in a complex system. And the key to achieving the right policy or program mix is to understand and use the interrelationships and dynamics between the parts, while assuming that each of our programs will need to adapt in a constantly evolving system. But there are some factors that work against us achieving this kind of approach. There are parts in the systems whose influence we may want to resist or overcome if we're going to leverage the strengths of this overall approach. One is around assumptions about the role of programs. We need to consider that, or challenge assumptions that one model or intervention is the solution and always will be, or that every model or intervention is automatically good or helpful. Not all interventions are complex. Sometimes it's a series of interventions playing their role in a complex and adapting system. Some interventions leave a lasting footprint, while others diminish over time, depending on how well the dynamic properties of the system can be harnessed and how rapidly the social and structural systems change around it. Another point is around investment in evaluation and evidence. We definitely have a lack of developed evaluation at the sort of community, structural and system dynamics level. We have a state and national research approach that tends to be relatively ad hoc and siloed, contributing to a growing distance between social research, epidemiology and surveillance research, and practice and policy. These factors play a reinforcing role in focusing attention on parallel ideas of programs and very linear ideas of programs, rather than an interrelated system approach. This then leads us to funding leadership structures. The siloed and competitive funding amplifies the pressure on organisations to position themselves for short-term security more than necessarily the larger, best outcome for the broader epidemic, partners and communities. This pressure reduces the capacity to strategise at a system level. Add to this a bit of a vacuum in national political leadership, and it's even harder to leverage overall national momentum. Viewing community leadership and advocacy initiatives as parallel and unrelated not only reduces their effectiveness, but risks minimising the opportunity to leverage a much larger and much more sustained combined influence. Advocacy efforts do not have to have exactly the same goal in order to actually amplify and enhance each other's impact. None of these are insurmountable issues, and we've overcome the same things at previous times in this epidemic. When compared to most other countries, the Australian HIV response has shown an adaptive and political active response, working across a whole range of multiple social, political, behavioural and health service levels, and operating in a supportive environment, is definitely the most likely to reduce the transmission and impact of HIV. And Australia's partnership has been fairly durable through this, circumventing barriers and building enablers. However, let's be realistic, a partnership across so many different areas of health services, community organisations, public health, law enforcement, political parties and activists, researchers and clinicians is not easy to maintain. Like a broader system in which they operate, partnerships are not static. In the same way as a community cannot live in a crisis mode forever, nor does a partnership response. Partnerships in times of crisis, which necessitate collaboration, are often more easily characterised and remembered as very successful. However, partnerships in times when the environment and the politics and the response becomes more complex are much harder work to sustain. Sustaining a continuously adapting and effective response to HIV requires all parts of the system to be engaged. But we need the levers to work in synergy and amplify each other, not just be additive. We need to think strategically about how each program's quality and effectiveness interrelates with the others, and how the mix needs to be continuously adapted in an evolving and adapting system. I believe right now is our best chance in decades to turn this epidemic around. We have additional strong levers with treatment as prevention and its related opportunities, with which to work alongside our well-established and other emerging levers. For the community sector to lead on this, we need a number of points. We need to be able to draw on and synthesise evidence from multiple sources, and that's not just evidence coming from research centres, as well as have the confidence to take action even when evidence is limited. We need to understand the role of community response within a broader system, and more importantly, translate that evidence into effective community-engaged programs. We need to continuously challenge and overcome personal, social and structural stigma and discrimination, and be open to identifying that when it's actually within our own programs. Be bold in the face of sensitivities and legalities around sex, sexuality and drug use, as we always have throughout the epidemic. And be willing to think and do differently to achieve the solutions our communities and demand and deserve. The last few decades have shown we can do all of that. While more